Asepsis and infection control. Give me your understanding of asepsis.
Clean environment.
Clean environment. Asepsis. What's your thought about asepsis? Yes.
Like you get in the hospital.
Okay. All right. You get in the hospital. What else?
Due to other diseases, like.
What does asepsis mean to you? What does it mean to you? Okay.
Like aseptic technique, like keeping it sterile, not necessarily sterile, but keeping it.
It does include sterility, maintaining sterile, yes.
Sterile technique.
Okay.
Keeping a generally infection-free.
Infection-free, bug-free environment, maintaining clean. Now, is asepsis limited to just the hospital setting?
No.
No? Where else should we be practicing aseptic techniques?
Actually, the food industry.
The food industry. Okay, the food industry. Where else? Oh, cafeteria. Where else? Where? Huh? Home care. So practically everywhere, asepsis should be, and it should be a concern, right? Let's talk about it. Now, when it comes to the infection cycle, which means how these bugs or the pathogens travel. Okay, you have the components of the infection cycle, which includes the infectious agent. You must be familiar with the agent or the pathogen. You have to be familiar with the agent. And those agents include bacteria, they include viruses, they include fungi. Is there anything else that's not listed on here? Prions. Huh? Prion? Is it prion? Okay, prions. Okay, what else?
Parasites.
Parasites, okay. All right, so you must know. Why should I know? Why is it important for me to know the pathogen that I'm dealing with?
So you know how to prevent it.
So you know how to prevent it. And what else? Somebody said?
To give the correct antibiotic.
Okay, be careful. What does antibiotic mean? Bacteria. So what's the more appropriate term is the appropriate antimicrobial. Because if it's a virus, can I treat the virus with an antibacterial? No. Okay, so this is why I say be careful. You gotta be careful in what you say. So you need to know the bug so that you know exactly how to treat or have a better idea of how to effectively treat this patient. All right? Then you have the reservoir. Reservoir is just basically where this bug is residing. That's all it means. Okay? So reservoir is a home where this bad boy or pathogen is residing. Portal of exit is how it's going to get out of its home and go someplace else. All right? That's basically what portal of exit is, how it's going to escape. Means of transmission is basically what vehicle is it going to utilize to get from point A to point B. Is it going to use a Maserati? Is it going to use a Lamborghini? Is it going to use a Toyota? Okay. Okay. In other words, specifically as it relates to transmission, is it going to be direct contact when I touch this surface? Is it going to be when I breathe it in or exhale it throughout the air? How is it that this pathogen is going to travel from one reservoir to the next? Does that make sense? And then the portal of entry, now that it has escaped and it used, like, for example, direct contact or indirect contact, and now it's going to go to a new place. That's basically the new host, the new home, all right? Now, you also have to be very careful or cognizant, I should say, of the susceptible host. What does that mean, susceptible host?
It has to get onto somebody that it can actually affect.
Okay.
So immune system compromise can make them more likely for whatever our infection agent is to actually affect their body.
Good. So susceptibility basically means how likely is this person going to be affected by this pathogen? That's all it basically means. All right. Are we cool so far? You need to know this not only to pass NCLEX if they ask you these questions, but also when you're going to protect your patient when you become a great nurse. Now, our goal as healthcare providers, specifically registered nurse, is to cut the chain of infection at some point. Okay, so you have these different elements that we just talked about, and these scissors that they show right here is basically how we cut the chain of infection. There's various means that we can utilize to cut the chain of infection at any point. For example, from infection, to keep it from traveling from infectious agent to another reservoir or a reservoir, we practice hand hygiene. That's cutting. Practicing hand hygiene is actually you cutting that chain of infection between those two elements. Does that make sense? Or because you know your patient is has let's say a TB, for example, the fact that you put on appropriate PPE, the right mask, that action right there, donning on appropriate PPE, putting on the correct mask, is you cutting the chain of infection right there. Does that make sense? Okay, so you need to know how or what means can we use to cut the chain of infection. Our goal is to always cut the chain of infection to make sure that bug does not keep on multiplying or thriving. All right? You already know the answer to these questions. So we already talked about the different infectious agents. Now, you must know the classification of those bacteria. Pathogens are classified according to their shape. You must know whether or not they're spherical, bacilli, which is rod shape, or corkscrew shape, which is fire seed, okay? Because that's part of your treatment, knowing the shape. Categorized by response to the gram staining. Is it gram positive or gram negative? This is all important for the appropriate treatment. And then it's also categorized by the need for oxygen. Is it an aerobic pathogen that needs oxygen to live, or is it an anaerobic? You got to get used to, make sure, I'm going to stop right here. You see, know your medical prefixes and suffixes. A or AN, anything, means without. Okay? Anaerobic, so it can live without oxygen. This is important for you to know. So for example, if you're doing wound culture or wound care rather, and once you culture that wound, the results tell you that this is an aerobic bug. If that bug needs oxygen to live, what would be your treatment, especially when you're trying to cut the chain of infection? Huh? Say it. Cover it, because if it requires air to live, then I'm going to cover it and compromise that oxygen for that bug to not live. Does that make sense? That's why you need to know if it's aerobic or anaerobic disease, pathogen, not disease. The other thing that you must be aware of is the factors that affect the organism's potential to produce the disease. You look at the number of the organism, and again, this is all going to be found in that culture result, the culture and sensitivity result that you do. Virulence is basically how strong that disease, that pathogen is, and the competence of the immune system. In other words, how susceptible or how weak, in other words, is that patient's immune system. And then the length and intimacy between the person and that microorganism. In other words, how long has this person been dealing with this pathogen? Just like how we had our patient previously right now, one of the questions that you guys asked was what? How long did you have this this cough, right? Because you want to know, right? Now, you want to also identify the infectious agents by, this is for stats, but endemic versus pandemic. Basically, endemic basically says it occurs with predictability to one specific region. So in other words, it's just a localized area. It's not the whole world. Pandemic, if you see pan, anything means the whole, that means the entire world is affected by this disease. Give me an example of an endemic infectious disease. Endemic, E-N.
Swine flu.
Huh?
Swine flu.
Why you say swine flu?
Predominantly like the South.
Because it was located in one particular region. The whole world wasn't affected by that swine flu. Now, we already know, I can give you a good example of pandemic disease, which is everybody and their grandmama and granddaddy was infected by COVID, right? So COVID was, for example, a good example of a pandemic disease. It's a global outbreak. Why should we as healthcare providers need to know this information?
Impacts our care.
It does. Okay, because you need to now know, okay, if it's endemic, how am I going to triage care, for example? How am I going to make sure that the patient is isolated appropriately, etc. So this is going to impact the type of care that you are going to render. Now, possible reservoirs, again, include other people, or people in general, animals, soil, food, inanimate object. You need to know where these bugs thrive, okay? And once you know where these bugs thrive, then you will know how to provide appropriate care, right? We already know the different common portal of exits. Common one being respiratory. So, for example, what would be a respiratory pathogen or disease? TB. Because if you breathe it, then you're going to get it, okay? Cold is another one. What about GI?
E. coli.
Huh?
E. coli.
E. coli. Well, yeah, E. coli can be in the GI tract. It can also be GU too. So E. coli is both. Yes, all right? GU, you already UTI, for example. Urinary tract infection, breaks in the skin, and then also blood in the tissue. So you need to know some of these common portals of exit. All right, how it's going to try to escape. Means of transmission, direct contact versus indirect contact. When they say direct contact, what does that mean, Nate?
Actually touching it.
Actually touching. I really got to touch you to get that pathogen. Okay, so do you know an example, or is it actually in your book, of a bug that thrives on direct contact? Staph is one of them. Yes. All right.
Tick.
Tick is another one. Okay. Indirect. Tick is not direct. No. Tick, isn't that the one that requires
They're effective.
Yeah, that's indirect because you got to get through a bug. Okay, tick is like a vector, right?
Mm-hmm.
So the vector. What is vector? I forgot what is vector.
Carrier.
Huh? It's a carrier. What does that mean, carrier?
It's a live organism that transmits it.
So, for example, a fly would be a vector carrying the bug. Okay, does that make sense? That's why it's indirect. You didn't directly get the bug, but because the fly actually was carrying it and then it laid on your food, boom, that's how you got infected. Or not, let me not say you, that's how the person got infected. Does that make sense? All right. Fomite, I forgot what fomite means. I don't know what fomite means. What is fomite?
An object.
Is it like the door handle?
Yes.
Inanimate objects.
So like the
Door handle, walls, tables, those are all fomites, okay? You touching that infected fomite or infected door handle, okay? Because the person just used the bathroom and didn't wash their hands because they was in a rush or just didn't think it was necessary. Now they touched the door handle, boom, and left their pathogen there, and then here you go, innocently touching that same door handle, boom. Here we go, infection, all right? Now, you also need to know another means of transmission is droplet droplet and then airborne. Please, I always get confused between those two. What is the difference between droplet? Please read the book. The difference between droplets and airborne. Don't guess. What does the book say is droplet, and what does the book say is airborne?
Droplet is more than 5 centimeters and can spread 3 to 6 feet. Airborne is less than 5 centimeters.
Give me an example of one pathogen that is droplet.
So we could say
It's in your book. Your book open right there. Your book right there open.
I wanted to call it from memory.
No, your memory might do you disservice.
Okay, so for droplet, it can be rubella.
Rubella's droplet.
Yeah.
What else?
Influenza.
Influenza's droplet. And airborne. What would be airborne?
COVID.
Anthrax?
Anthrax is airborne?
I think so.
Oh, I don't know. You might be right, but let's validate that. Can we validate to see if anthrax is airborne? Is an airborne disease?
It's not just airborne. I think you can touch
Yeah,
it.
TB is airborne.
You sure about that?
It says for respiratory anthrax, yeah.
Oh, okay. All right. You sure TB is airborne?
TB.
Yeah.
Yeah.
You think so? I don't want you to think so. I need you to know. So
Yeah.
why y'all don't?
It's
What y'all gotta just opening your book to
It's
like
there.
validate the information, huh? You see it?
Yeah.
You sure about that?
Yes.
Are you sure TB is airborne?
Yes.
Why? How you sure?
Because it says it.
Okay, just
Anthrax is both.
and
Airborne and direct.
and what? And direct. That's why she had to go back and clarify and say respiratory anthrax is airborne.
That's the bad one.
Okay? No, because you're right. It can. Some pathogens can be spread multiple ways. You need to know that again, so you could break that chain of infection or that cycle, I should say. All right. Now, you must know. I'll be honest with you, just for this class, because after that, you probably ain't gonna see this maybe till fourth semester. The stages of infection. Okay. The stages of infection are incubation, where it's just it's cooking. All right. The bug is cooking up a storm in the oven. Right. Prodromal stage is where the person becomes the most infectious, and sometimes during the stage, this person may not show any signs and symptoms during the prodromal stage, all right? Or if they do become symptomatic, the symptoms are kind of very vague during the prodromal stage, all right? Full stage of illness, this is where now you start to see specific signs and symptoms, just like our clients in the back, right? They started showing their backache and started complaining of this, that, and a third. Now you start to see the full stage. And then you have the convalescent period where our client starts to recover from infection. Now, based on our client this morning, what stage would you put our client in? From our client this morning?
Full stage of illness.
Huh?
Full stage.
Full stage of the illness, because they still, she still has some signs of what signs and symptoms show you that she's at that stage.
Dry cough.
She has a dry cough.
Body aches.
She's still complaining of body aches. What else?
Temperature.
Spewed up. She's spitting up a storm. Okay. Now, what would show you that the client is in the convalescent period stage?
She's not coughing.
The symptoms are improving.
You start to see improvement in the symptoms, okay? They're starting to get better, right? So we're not there. This is what we always, as healthcare providers, are working towards, the convalescent period, all right? Now, I must say to you, not all clients make it to the convalescent period.
Right.
Not all clients make it to the convalescent period. It really, and this is a problem I have with this diagram, so it really goes like this. From stages of the period, you go, stages would be, you start off with incubation, then you go to prodromal, then you go into full stage, and this can go either way. You either die or you either recover.
What is NCLEX?
NCLEX is not going to be specific and ask you this, they're going to give you the scenario.
So,
And you just need to know how to either know the assessment to look out for or how to intervene.
they won't ask you for like the last stage.
They won't ask specifically that say, oh, how do you know the patient is in convalescent period? It ain't gonna ask you those type of questions. They're gonna present to you the scenario. If they're gonna do a case, they're gonna, based on how you answer, you're gonna know if the patient is getting better or worse in the case. They do NG and case scenarios, okay? All right, so that's the stages. Now, you must know that you have to know. This information is going to follow you up until you stop nursing.
Until I die.
Yes, okay, because you gotta know this. You cannot be a nurse and not know this information. The inflammatory response. The response basically helps the body neutralize, control, or either eliminate the pathogen, the bug that is offending the body. Okay, that is what the one of the things that the inflammatory response does. Okay, then you see it occurs in response to, of course, the infection or an injury. So let's say while the client was walking and they stubbed their toe on a nail. So what happens with that toenail? What happened here? Okay, then you start to see either redness, you start to see inflammation, some edema, etc. All right? Now, you must know with regards to the inflammatory response, it can happen where it's either acute or it could happen in a chronic situation. Explain to me acute versus chronic again, especially specific to the inflammatory response. Acute versus chronic.
It's like an injury that just happened, and chronic could be like a disorder or disease.
Okay, it can happen as a result of a disorder or disease, or it can happen as a result of impact that happened a long time ago. Okay, so yes, all right. Now, with regards to the inflammatory response, please make sure you know the phases. It goes into a vascular phase and it then goes into a cellular stage. Vascular phase, this is when you start to see that redness. Make sure you know your medical terms, because the book, or the question rather, may not say redness, but what's another name for redness?
Rhubarb.
Oh, okay, cool. Because they're not going to be looking at me like crazy, like, I ain't saying the word erythema. Okay, you better know your words. Or histamine release caused by permeability of vessels. In other words, you might see swelling, like I said, okay? Or loss of function, or pain. At the cellular stage, this is where you start to see the white cells, or specifically the leukocytes, start to act up, all right? And the damaged cells now are fixing themselves. Now, as it relates to immune response, because remember, the body's always trying to stay alive. I think that's how, like, Dr. Sullivan likes to say it, right? The body's always fighting to stay. Oh, I mean, let me. I'll make sure I edit that out the script before she get it mad at me. Okay? So the body's always fighting to be in homeostasis. Make sure you know this word, homeostasis. What does homeostasis mean?
Happy stage.
Happy stage, balanced, okay? You are going to hear that word a lot throughout the nursing program, especially in your med-surg book, okay? Now, as it relates to the body trying to stay alive, in specifically to the immune response, the body is protecting itself. It got these soldiers, specifically, that is protecting the body to defend itself against any pathogen or bug. So you have humoral immunity, where you have that includes an antigen. An antigen, you must know, is a foreign material, foreign body. The body doesn't recognize it, hence the word antigen. The body is going to act against it, okay? So that could be like a bacteria, that could be any of those pathogens that we talked about, fungi, etc. You can also have, as it relates to humoral immunity, antibody. Now, this antibody is what's produced by the body to defend itself against the foreign object. Are we cool on that? This is very important for you to know, because when you're providing certain care for a client, you need to know this is why you need to know how long they've been exposed to this pathogen. Because now their body is developing more and more antibodies or antigens and stuff like that. And sometimes it can be okay for the client, but in certain situations, it may not be well. Outside of immunity, okay, or infection control. For example, this is why when a patient says, what disease I could say, okay, let me use sickle cell, okay? Sickle cell patients, they tend to get blood transfusion, okay? you want to know, any client especially who has blood transfusion, you would want to know how often have they been having blood transfusion. Because the more you have blood transfusion, the more your body is going to develop antibodies. And now the more antibodies your body develops, now it becomes harder for blood banks to develop a specific type of blood product for you, because they got to make sure that blood product works for your body, not against your body. Okay, for example, that's one thing we learned in response to antibodies, antigens. All right, back to immunity. Then you also have CMI, or cell-mediated immunity. This now is where there's an increase in lymphocytes. You see that with your white blood cells. Then these lymphocytes, they just basically eating up and destroying those cells that are deemed dangerous. That's what they're basically doing, okay, with regards to cell-mediated immunity. The white cells are just destroying any foreign objects that's going to be harmful. And sometimes now, the body can recognize its own self as being harmful to itself. What is that called? Autoimmune. And you have several types of autoimmune diseases. And that's when it becomes more and more dangerous for that client, because now the body is fighting against its own self. Okay? Now, factors affecting the patient's risk for developing infection include, of course, the condition of your skin. If your skin is intact, we Gucci. Okay? Even Ferragamo and Prada, we good. Okay? Skin is intact. That's why one of your assessments, depending on the need, of course, would be to look at the patient's skin condition. Okay? We're going to look at pH levels. If your pH levels is abnormal, did Dr. Sullivan show you Rome yet, or acid-base balance yet?
We could go over it again.
Okay, I'm gonna go over it very intense in a little bit, okay, later on, okay? So we're gonna look at the pH levels. If your pH levels are abnormal, that can predispose you to infection. The body's white count. Okay, you see, the body's white count. Now, this week is the week we are starting to look at numbers, and we are not playing with numbers outside of your normal, the little stuff like kilograms versus pounds and ounces and stuff like that. I'm talking about lab numbers. Anybody have any idea of what your white count number ranges should be? Give or take.
250 to 450,000.
No. Huh?
5,000 to 10,000.
5 to 10,000. 5 to 10. Now, in your book, it's 5 to 10. I know in other resources, references, there's going to be slight variations. Welcome to the reality of healthcare. That's why you always have what's called a reference range. Each facility will have their own unique reference range depending on the population, the geographic region, etc. for the client that they're taking care of. But right count is 5 to 10. Now, other factors. I could get age, because as we age, our body tends to decline. But I don't understand what gender has to do with anything. How does gender affect my ability to contract an infection or get infection?
Is it sexually?
Some diseases are your gender hereditary. You might be more prone to getting something. Like men get Burger's disease.
Burger's disease?
Burger's disease.
What is You said burgers?
Burgers.
Burgers, like hamburger?
Well, that's how I remember it. I like burgers. So I like burgers.
What is burgers? I've never heard of burgers.
It's really
Like
good
the male version of
in their
Raynaud's.
extremities, and so they got tissue back from their fingertips. Not to be mixed up with Raynaud's, which women are more prone to get Raynaud's.
Oh, wait. So explain the burgers again?
I believe it's where they get occlusions
In their fingers.
in like in their fingers and like their extremities.
I'm gonna look that one. I'll be honest with you.
They turn black from necrosis.
And they get necrotic?
Yeah.
I should be ashamed. Maybe
I like
this is something I
burgers.
should have known. Okay, so that's one. What's another in terms of infection? You gave me a non-infectious disease.
UTI.
Oh, what about UTI?
Women are more prone to UTIs than men.
Why is that? Because of the anatomy. You see, when I told y'all, make sure you know your anatomy and physiology, this is one of the reasons why. Okay? So that's one example. Okay, and there's a plethora of other reasons why infection, the risk of infection is gender-based. It can be gender-based, okay? And then, of course, hereditary factors. Now, immunization. Were you did you get vaccinated or not? Was it natural or acquired immunity? What's natural immunity? Say it again. You were born with it, and then acquired. You get it later on. What are the different ways you can acquire immunity against a pathogen? Say it again. Vaccine is one. What's another one? Exposure. I don't know if y'all do this in if y'all do this at all, but one thing Haitians like to do, especially when it comes to chicken pox, one time, okay, one child gets chicken pox, that's when everybody, instead of isolating yourself, no, everybody's gonna get exposed to that bacteria so we can develop strength against it. Huh? Yes.
I remember when that
Pox
happened.
party, yes, huh?
I remember when that happened. I was in like kindergarten or preschool, and one kid got it, and everybody made sure their kids were there that day.
Really?
Somewhere else, and did go into the classroom and stayed together.
Yeah, so
Made
we
us
could
feel-
all.
So I thought it was just a Caribbean thing. My bad. Okay, so everybody does that. Okay? Now, what's the theory behind that?
Less severe when you're younger.
Yes, severe, yes. Because your body, when you're younger, your immune system is stronger, because if you get the chicken pox, so to speak, later in life, especially an older adult, bro, you're not going to be a happy camper.
There was also a lot of trust issues with it, because the chickenpox vaccine was still kind of new in the early 90s. So a lot of parents they didn't want to give their kids shots.
Shots.
They knew the pox party, they would all get it and get immune anyway.
Yep. Okay. It was a good way to develop the strength. Yes.
Question. So, if you get chickenpox later on in life, is that still chickenpox or is that shingles?
No, that's shingles.
Oh, okay.
That is shingles. It's no longer. It's just now the extreme version of chickenpox, and it is not.
Get it when they were younger.
If they didn't get it when they were younger, and it's important to know because, for example, now as a healthcare provider, let's say you were never exposed to I don't know why I was gonna say chickenpox, but you were never exposed to chickenpox, and you're going to now take care of a client who has either chickenpox or the shingles. Your superior should be aware of it so that they can organize the care. Because if you go and contract it, bad, especially if you're not vaccinated against it. Okay.
So it's still considered shingles even if it's their first infection as an adult?
I think so. Yeah, they could. Yeah, I believe so. No.
Because isn't shingles when it's like dormant and then it like reemerges because it's in the spine?
Yeah, that's
I
what
think you
it
can only get
was.
shingles if you had chickenpox.
If you had the virus inside of you, yeah.
Oh yeah, but it's still chickenpox. It's still the same pathogen. It's just
It's a different
like,
presentation.
presentation. Yeah, it's just a presentation of it. Okay. Yes. All right. Now, other factors that impacts a person's chances of getting infection: fatigue. That doesn't happen in nursing school. Y'all never tired. Okay. All right. Or climate control, nutritional or general health. If you're not getting your vitamin C or enough vitamin C, or if you're not, like our client, hydrated enough, only drinking tea and calling it a day, just a little bit of tea, I don't know, okay? Stress. Now, while we can understand nutrition and climate, I don't understand how stress can cause a person to be increase their chances of infection.
Well,
Cortisol. What? Okay, you say glucose. Why?
Because when you're stressed, it's gonna affect your output of glucose, and then that's what like bacteria will feed on.
Because some bacteria are sugar loving. Okay. All right. What else?
stress flares up the immune response inside of your body.
Say it again.
Stress will flare up an immune response.
Stress will flare up or can flare up the immune response. Yes, okay? So what does that mean? And don't say don't go to nursing school, okay? All right? But you want to address a patient's level of stress. Because if they're constantly getting affected, this is one factor you probably want to look at. Where are you working at? What is your living conditions like? What are some things that are causing you to be stressed at all in the first place? Because the longer you are stressed out now, if you're stressed for just a couple of hours to one day, you know, in terms of anxiety and stuff like that, dealing with a situation, no, that's okay. It's just a long-term stress. When you're stressed for a long or an extended period of time, that's when it can compromise your immune system, okay? And then another factor is invasive or indwelling medical devices, like a Foley catheter, like a PICC line, like an NG tube. If you can avoid inserting an indwelling catheter like a Foley, please, by all means, definitely avoid it. Now, if a client needs to have a Foley catheter inserted, by all means, good. What would be a good reason for a client to, for you to agree to have the patient have a Foley catheter? What would be a good reason? Huh? Retaining. What did you say? Surgery? Okay, yes, because some surgical procedures, because of the anesthesia. Okay, what's another? What's a bad reason? What's a bad reason to insert a Foley catheter?
If they're mobile, basically.
They say, oh, I don't, you know, clients will tell you, oh, insert the Foley catheter, I don't feel like getting up, and they're perfectly mobile. Another common reason why healthcare providers or nurses would want a Foley catheter inserted, because they're incontinent. Incontinence is not a reason why you should have a Foley catheter inserted. We're going to try other means, like we're going to turn you, not turn you, but ambulate you as safely as possible to the bathroom. We're going to do bladder training or schedule or something. But incontinence is not a reason to have a Foley catheter inserted. Now, if the client has a wound in the perineal area, and we know that urine can cause wound to be more infected, and they are incontinent, now that's a valid reason to have the Foley catheter inserted. Does that make sense? So you need to know why you are doing what you are doing, because we know that indwelling medical devices can increase the patient's risk of infection. We see white count. Don't play with me. Don't play with me. You hear me? Don't play with me. And yes, I will give you numbers. I will say a client has a white count of, 11,000. How do you intervene? Now, people, while it is nice that you memorize that white count is 5 to 10, whoop-de-doo. Whoop-de-doo. Yeah, we memorized that. But guess what? In the real world of US of NCLEX and also in the real world of nursing, knowing the normal reference range is not enough. What other information do I need to know as it relates to white count, for example?
Baseline?
Huh?
The patient's baseline.
Okay, patient's baseline, good. What else?
Abnormal lab levels.
You do, okay, since we know that's good, since we know 5 to 10 is normal, we already know anything outside of 5 to 10 is abnormal, good. What else do I need to know, especially for testing purposes? Signs and symptoms of what, Shirley?
Signs and symptoms the patient's experiencing, basically.
When the results are abnormal, you need to know what the patient will present as if their white count is 2K, or if their white count is 15,000, 20,000. You need to know that. Okay? Don't play with me. Yes.
I have a question. So why would a patient's white blood cells be low, and then why would it be high? I know it's infection, but what makes the difference?
So, certain disease process. For example, cancer. Certain cancers will cause the patient's white count to be depleted. Certain cancers, certain diseases, certain changes. Like, for example, an OB patient who is delivering a baby, right? Their white count is expected to go up. So it's just physiological changes of the body that causes the white count to be up or down.
Medications.
Certain medications. Thank
If
you.
the patient has a bunch of wounds, would their white count be low?
The white count may be actually high. High. Usually it's high. It could be low. It's rare that I see it low, but it's mostly usually it's high. Okay? When the, for wound.
Necrotic, would it be low?
Huh?
If the tissue's necrotic, then it would be low? Or
If if it's necrotic, it's just dead. It's just dead. Okay? It's rare that a necrotic tissue now is infected. It's just there's nothing to live for that pathogen to live by. I mean, depending on, of course, of that type of pathogen, but usually it's just dead and they get rid of it. Okay? Good question.
I have a question. So if there is so much infection that the white blood cells can't keep up, would you start seeing lower levels? Like if it's overtaking the white blood cells?
The disease? I'm not saying no, I haven't heard of it, but I'm not saying no either. Like the disease takes over the body so much that the white count can't keep up it. So now that what will end up happening is the white count is now low. So now your treatment is going to be different. They do what some treatment might be like, I forgot the correct name of that treatment.
For what?
When your white count is so low, now you need to have your white counts replaced. Anyway, the treatment of care is going to be different, okay? Other labs that you're going to look at, of course, is the ESR. I have never heard of in my life ESR or erythrocyte sedimentation rate. What in the world is that?
Non-specific.
Non-specific what? What do you
Marker
mean?
of inflammation.
Huh?
It's a non-specific marker of inflammation.
Okay, it's a non-specific marker of inflammation. So they're looking at, they put your little blood. They put your blood in like this little tube, and then you look at this, how the sedimentation of it, and then boom. When that ESR rate is elevated, that means most likely you will have an infectious process going on. They also look at other body fluids, such as your urine. They look at your blood. They look at your sputum. And they look at anything that is draining or oozing out of your body, and they collect it. Now, if you, as the fantabulous healthcare provider that you are, you suspect that the patient has an infection or whatnot, what are you going to do? Let me make it more specific. Let's say you come in, the patient has a wound and it's oozing. What do? Oh, okay, boom. Also, you must know that when you are dealing with, a wound and a possible infection, what are some other treatments that you're going to incorporate?
Treatment?
Yeah, treatment. Yeah, you swabbed it, boom, what else? Boom.
Antibiotics.
Hydrate.
Okay.
You would do blood cultures.
You would do blood cultures, you would do wound cultures, of course, and then yes, you would start an antimicrobial, broad spectrum antimicrobial, because you don't know what you're dealing with. You just see oozing stuff coming out of this patient's wound. I swabbed it, but treatment needs to start anyway. So usually you start with a broad spectrum antimicrobial, something like Levaquin maybe. And then when your results come, which usually takes about 1 to 2 days, sometimes even 3, okay, but usually within 1 to 2 days, it'll give you what the pathogen is, and it'll let you know whether the pathogen is sensitive or resistant to certain antimicrobials. For example, let's say you have, give me a bug.
C. diff.
C. diff, okay? C. diff. Now y'all know it's gonna be Clostridium difficile, right? C. diff. That's what the results tell you. Then you'll have, it'll say, for example, azithromycin, or something like that, azithromycin, sensitive. It'll say cefepime or something like that, resistant. If it's sensitive to azithromycin but resistant to cefepime, what would you expect the doctor to order then? Azithromycin, because that bug is sensitive to azithromycin. Does that make sense? If it's resistant to cefepime and that doctor orders cefepime, what are you doing?
Telling them.
Don't you ever say you do nothing. Recommending what?
To go with the person.
Yes, okay, or something else that it is sensitive to. Doc, you want to change this? Now. You also have to deal with the other thing. You see the assessment that I always have y'all do. I have been making y'all do since week 1, assessing for pain and what else? Allergies. If the patient is allergic to azithromycin, you're gonna look for, hopefully there's something else that it is that bug is sensitive to.
Wouldn't they be related? Wouldn't the drug be related?
Now, if they are like penicillins or any penicillins, for example, if they're allergic to penicillin, now they're gonna use something else. Okay, I'm trying to think off the top of my head, but Augmentin is not a good example right now. Why can't I think of a good? What's a good
GI?
No, anything. C. diff. I just need another antimicrobial.
Metronidazole.
Okay, Metro. Okay, which is Flagyl. Okay. Hopefully if the patient is, now realistically speaking, they're not going to use metronidazole. But I just want you to understand the concept, okay? If that bug is resistant to that antimicrobial, we are not using it. And the other thing you're going to factor in is the patient allergic to that antimicrobial or not? Those are the 2 main things you need to consider when you're starting treatment. Does that make sense? And that's a great question. If they are allergic to the penicillins, you're going to look for anything that is outside of the class of the penicillins that the patient is allergic to hopefully treat and effectively treat that infection. Yes?
What were the 2 things? You said assess for allergy and then
the resistance of to that bug. Okay? In other words, if it's resistant to cefepime, you're not using it. But if it's sensitive to azithromycin, then you recommend that. All right? Okay, so we have where we're going to get our sources, of course, bodily fluids, and then the outcome. What are we looking for? Because we ain't doing things just to get paid, okay, and sit here and look pretty. No. We are doing things because we have a specific outcome we're looking for, especially when it comes to infection. What's our typical goal?
Free from infection.
That they're free from infection, okay? Because that's the business that we're in. So our goal is that the patient would demonstrate effective hand hygiene. Most of the time, the correct answer is hand hygiene. Y'all notice what I said? Most of the time, the correct answer is hand hygiene, not all of the time. What are you going to do? Read carefully. Okay? Don't play with me. Okay? And then identify, maybe your other goals could be that the patients identify signs of infection, they know how to eat right, nutritional intake. Now, throughout this program, and even in NCLEX, you do need to know your nutrients. Okay, your nutritional status, right? One of them is going to be not just only what are some nutrients that'll help against infection? What are some nutrients?
Vitamin C.
Vitamin C. What else? Anything else?
Zinc.
Yeah, zinc. Okay, collagen and all that good. Well, collagen is for skin. My bad. Okay, zinc. Okay, so you need to know. Not just vitamin C that is good, for example, against the infectious process. What else should you know? Where can I get those vitamin C from? Okay, this is part of your teaching. Where can we get vitamin C from, people?
Citrus.
Okay, citrus, orange juice. Okay, that's a common answer. All right, very good. And then, of course, use appropriate cleansing and disinfecting techniques. Demonstrate awareness of necessity of proper immunization, and of course, demonstrate stress reduction techniques. You are going to show if stress is the issue. Listen to me, because I know how y'all like to be extra with these questions. If stress is the issue, then your goal is going to be what? For the patient to demonstrate stress reduction techniques. What are some stress reducing techniques?
Taking a deep breath.
Taking a deep breath. Okay, good. What's another stress reduction technique?
Calming music.
Calming music. Okay, these are some of the teachings that you are going to incorporate. All right. Now, this right here, please, people, don't play with me. Aseptic. Asepsis is basically where your intention is to prevent infection or break the chain of infection. You either are preventing it or breaking it. You must know that there are two main types of asepsis. You have to know this. Guys, you must know this until you stop becoming a nurse. I don't care what anybody says. There is medical asepsis, and then there is surgical asepsis. It's very simple, people. Medical asepsis is just basically you just keeping it clean. Hand hygiene, wearing gloves, those kind of things. You just keeping a clean environment, as every environment should be. Surgical asepsis now is in addition to medical asepsis. Now you are going to make sure not only is the environment clean, but that it is bug-free. Does that make sense? Just because it says surgical asepsis, that doesn't mean you eliminate the medical aspect. It's in addition to. Do not trip on that question. Are we clear? You understand? You understand? You are not going to trip when that question comes up at some point in this term? Okay.
A's without.
Huh? A's with the So of all the things I've been talking about, that's the only thing you got A's without. All right. So medical, and then in addition to medical, you incorporate surgical. This is when you do your sterile gloving, because remember, before we even don on our sterile gloving, what we doing? Hand hygiene, right? What do I stress y'all about? Cleaning your workspace, right? And then now you're going to incorporate the sterile technique. All right. Now, you must know which skills require medical and which skills require medical and surgical. For example, if you're going to go and collect poop for fecal occult blood, are you doing medical or are you doing surgical? Medical. Huh? For poop. Okay? All right. If you are going to insert a nasal gastric tube, this is a tube that you're going to put down their throat. First in through their nose, down their throat, into the stomach. Medical or surgical technique? It is medical.
Yeah.
It's medical. NG tube insertion is medical. Now, y'all should know this. Foley catheter. Don't play with me, okay? Do not play with me. Yes.
So medical is like using regular gloves, and then surgical would be sterile gloves?
Sterile gloves, yes. And so sometimes to even get to the
But you still gotta clean yourself.
You still gotta clean yourself.
Surgical.
Yes. Okay. All right. Very good.
Would IV insertion be
Oh,
surgical? Because it says in the book it's a surgical.
IV insertion. IV insertion is surgical.
That's what I'm asking.
If it's a
Where it says that?
port, it's
It's
surgical.
surgical.
Are they referring to?
Okay, hold on. Wait, let me address that real quick. Intravenous. IV stands for intravenous. If it's like a peripherally inserted central line, that is surgical. But if it's a peripheral line with a short, that is medical. I'm glad you brought that question up.
Say that one more time.
Okay, if it's like a line that is that's indwelling and it's more invasive, all of these, intravenous is invasive, point blank, because it's cutting the skin barrier.
You mean like the long-term ones?
No, it's not in a sense of long term, it's not in the sense of how long you're going to use it, but it's the fact of that it's indwelling, like it breaks the skin barrier, you have to go in, right, to insert the IV, you break the skin. However, if it's a peripheral, that's one that's very short. Okay, I don't know why this thing is moving, but the one that is very short, like the 20 gauge or the 18 gauge IVs, you have no idea. You're looking at me like, Dr. Semi, speak English. You're speaking Chinese right now. Okay.
But would it be like the size?
I understand
No.
I understand gauging and stuff, I just don't know.
It's shorter.
Different.
That catheter is shorter.
It's because
As
of
in
where
where
the
it's going?
catheter is.
It's just going straight to the vein only.
Really location. Like a central line is gonna go.
Huh?
The location, is that?
It's not only, location is not the only factor, but the length of it. So the peripheral IV is much shorter, okay? The catheter is shorter. Oh man, okay. If I get a chance, I'm gonna go into the lab and I'm gonna show you an actual peripheral IV,
If
okay?
there's a question though, like how would we know the difference?
Because if it says peripheral IV, that's it. But if it says PICC line, like peripherally inserted central catheter, because central catheter, it's longer. It goes from, usually they go into the AC and then all the way, it ends up into the top of the superior vena cava. That's surgical, okay? Even a midline, that is going to be surgical because it's a longer invasive catheter.
And an arterial line.
Yeah, arterial line, surgical, yes. But we as nurses, because we don't. I'm learning now that like PICC line, I'm learning that some nurses are actually doing. I know registered nurses did PICC line, but I thought you had to be trained. Some places I'm learning.
There's that extra certificate you can get to run the ultrasound to be able to.
Yes, I thought you had to be certified to do it, but hey, I guess it's different from
They
different.
are.
Yes,
So you said like the regular IV is medical,
medical, regular peripheral IV is medical.
like a more permanent one, like a.
I don't want you to say permanent because PICC line is more. I want you to think of it invasive. It's more invasive. The length of it is longer because you can have a PICC line and you only have it for like a couple of days just to have a medication done, administered.
Okay.
You understand? So it's not a term in terms of but the length of that catheter. A line, okay, which is arterial line. That's surgical. Okay? All right. I don't know. This thing is doing its own thing. Okay? Good question. Okay. Y'all should know this already. When you're doing hand hygiene at all times, okay? Y'all already know it. Before you even touch the patient, some people even go as far as before you even go into the room, they're doing hand hygiene. But definitely you need to know is before you touch the patient, before you start your procedure, after you've been exposed to a bodily fluid, after touching the patient, and of course after touching the surrounding areas of the patient's room. Bacterial flora you need to know is either transient or it resides. So transient bacteria are attached loosely on the skin. You just do a little hand hygiene, a little friction rub, and then it goes away. And then you have the resident bacteria, which is basically it's found in you gotta go in, like you lift the creases, you know what I'm saying? And then, why are you making that face? She's making that face, okay? And it requires you to do now more vigorous friction to get rid of that bacterial, okay? Or even a brush. Because it's in there. It's all up in there, okay? In the creases and stuff like that. Now, you must know there is this thing called HAI, healthcare associated infection. Now, let me ask you, what is healthcare associated infection?
Like getting it in the hospital.
Yeah, you ain't even come with the bug. You came in as an innocent person, clean, but because you came into the hospital, now you got a bug, okay? Healthcare associated infection. How can one be exposed to a healthcare associated infection? Again, CARDI, because you had an invasive catheter inserted, for example. One of the things that you'll see is that they have these bundles in each unit, or I shouldn't say each unit. In certain units, they'll have bundles according to what's going on in that unit, the rate of infection and stuff like that, and the cause of that infection. CARDI is catheter-associated urinary tract infection because if that infection rate on that unit is high, this goes back to quality improvement. Now that unit manager is responsible to minimize the rate of infection in that unit. So one of the things they're going to do is If the patient does not even need a catheter, Foley catheter inserted, we're not getting one. They're questioning physician's orders for one. Patient who has a Foley catheter, what can we do to remove that Foley catheter? Is it necessary to even keep it in place, etc.? Certain facilities now, to reduce, if the patient actually needs the catheter, the Foley catheter inserted, instead of one nurse inserting the Foley catheter, they have two nurses. I know I had to teach y'all one, you doing it individually, but now they're having two nurses actually. One nurse remains the clean nurse, while the other nurse remains the sterile nurse. Those kind of things, okay? And then another HAI is surgical site infection. This is an infection, of course, in the OR suite. Did we do our timeout? Did we make sure we did our counts in hand hygiene, apply the our surgical gloves correctly, etc.? CLABSI is central line. This goes into like your A lines, your PIC lines, your CVP port, your CVC ports, etc. Okay, and then they have MRSA. This is very common. Almost everybody and their granddaddy is getting MRSA. Okay. This is because of being in a hospital setting or a clinical setting. The MRSA rate has gone high so much that, let's say a client is transferring from one unit to one facility to another. One of the first things they're doing is swabbing that patient's nose for MRSA, so that the new facility is not responsible for MRSA if they caught it, okay? And then of course C. diff. Do we know what causes C. diff? What are some things that causes a patient to have C. diff?
Like not washing their hands after using
Too
it.
much antibiotics.
Not washing, huh?
Too much antibiotics.
Too much antibiotics, yes, okay? Sometimes even being on certain feedings is also a reason why clients get C. diff, okay? All right. Now, multi-drug resistant. This is where, again, your culture and sensitivity, the swabbing plays a crucial role. All right? So you are going to do swab the patient and look out to see, are they resistant to MRSA? Are they resistant to vancomycin? Are they resistant to carbamazepine? And, okay, I just say Bugatti for this one. I can't. And then C. diff, okay? You're looking to see what they are resistant to. Now, if the person becomes resistant, MRSA is very challenging to treat. Now that means they have to now treat the patient with a more stronger antimicrobial, okay? So you want to try it all as much as possible to prevent the patient from even contracting this. This is why breaking that infection cycle in the beginning is very important. Yes.
So is this like saying that these are the typical drugs that can be resistant?
No, it is saying that pathogen is resistant to that drug.
These type of drugs?
Yes. Okay, so the patient, in other words, develop a pathogen that is resistant to methicillin. Pay attention. If the patient is resistant to methicillin, what order are you questioning? Methicillin. Okay? Do not trip on that question because that option has something you are not familiar with. Hint, hint. Keeping it moving. Okay? That answered your question?
Yeah.
All right. Factors determining the use of sterility and disinfection, of course, this is pretty much self-explanatory. Number of organisms, the type of equipment used, why we're using that equipment, all of these factors determine how we're going to sterilize those equipment. All right, PPE, guys, y'all are pros at this now. Y'all know how to don on PPE, y'all know how to doffing and man, okay, y'all know how to put it on, y'all know how to take it off, okay? Let me tell y'all something. Okay. Relax.
Techniques.
I know, right? Because I don't want no trouble. How do you remove your PPE?
Gloves first.
So, say it louder.
Your gloves first, and then your gown.
And if you remove the glove first, how are you removing the gown?
Only touching the inside part.
Okay.
Touching your body.
Good. And then?
Gown, okay. And then your goggles. And then you step out of the room before removing it.
How many methods are there to removing your PPE?
2.
2. What's the other method? What's the other method?
It's like the way you take your gown off. But like, I don't know, like.
Okay.
Wait, let me think. Okay. So,
The first method, she removed the glove and then the gown, etc. The second method is
oh, you could do it with the gloves, right? And you could just rip it off.
you rip off you do the glove and the gown first. But if the question say, which one should the nurse remove first? What is the answer?
Okay.
Does it matter which method you yourself use? Don't play with me. Okay? You have been warned. Okay, I don't know what spirit this is. Okay? All right. So make sure you know how to take on and take off your PPE. And guys, the little shoe thing, cover thing is not typically an official part of the PPE. It depends on the setting, but you don't always have to put it. All right. Now, people, who gets standard precaution? Who gets standard precaution?
Everybody.
Who gets standard precaution?
Everybody.
Oh, no. Let me do I get to step outside?
Everybody. Everybody.
Who gets standard precaution?
Everybody.
Everybody gets standard precaution. No matter what you came in with, what you do or do not have, everybody gets standard precaution. Everybody gets hand hygiene. Everybody gets appropriate PPE. Standard precaution is basically making sure you take care of yourself and protect yourself and the patient, etc. Looking to see if they have exposed or non-intact skin, those type of things. That's standard. That's standard. Now, there is transmission-based precaution. Just like with surgical versus medical sepsis, transmission-based now is in addition to standard precaution. Y'all hear me? In addition to standard precaution, you must now add an extra layer of precaution for this client. You have transmission based. So this is where you have your droplet precaution, your airborne precaution, your what's the other one? Contact precaution. What's another one? Oh, let me write this down because y'all are not about to shame me. You have droplet precaution, airborne precaution, contact. What else?
Is there one for cancer?
What's the correct name? It has multiple names.
Yeah.
So they call it protective or neutropenic.
Neutropenic, yes.
I feel like I'm missing one. Some others. Why do I feel like I'm missing someone?
And standard.
Well, we said standard. Everybody gets standard. You see? Hey. Good thing I'm not superstitious, because I would have left y'all in this classroom by yourself. Okay? So in addition to standard, you must apply this. You gotta know what this means with droplet. Now, let's say the patient has airborne precaution. That means everybody who's coming into this patient, the patient has to be in airborne isolation. Everybody who's coming into this patient's room has to wear an appropriate mask, for example. Okay, like, what's the mask? Do y'all know the name of the mask? N95. But let's say the patient has to now travel outside of the room. Does that mean the whole hospital have to wear N95?
No, patient.
The patient now wears N95. Don't trip. Don't play with me. Bon, I'm about to leave you. Okay? Does that make sense?
Would the air precaution also applies to like negative and positive pressure?
Oh. I don't have no nice looking sticker, but take a sticker. What does that mean? What do you mean?
So, like, if the patient is sick, like, right, and then
Give me a disease with
TB,
TB.
and they're isolated.
Mm-hmm.
So, anything, so the negative pressure, like whatever is in that room, if you open the door,
It does not go. So the what's outside does not come into the room. Now, where does it go though? Because the patient with TB is in that room with TB. So where does it go? Out somewhere into this vent. And it does go out through a vent. Seriously speaking, if there is a special vent for that particular type of room, and they actually take the pathogen somewhere, not take special precaution. All right. Very good. Now we are clear. What does transmission-based precaution mean?
In addition to
Say it louder, please.
in addition to standard precaution.
In addition to standard precaution, what? What? You know, you just thought you can't leave me hanging.
Like additional precautions.
Additional precautions. So in addition to being hand hygiene, appropriate PPE, we are now applying, making sure that, we wear the appropriate mask, like N95 mask, or we make sure that the patient has a negative pressure room, etc. Okay? Or for contact precaution, let's say the patient has C. diff, which is contact. This room is going to have a designated equipment. Or if the facility or the unit cannot afford designated equipment, because let's be for real, not every unit has 10,000 good working vital signs machines waiting for us, okay? What we will do is prior to coming out of the room with our equipment, we are going to make sure we clean the equipment with the approved solution, hospital solution. Does that make sense? Yes. Okay? So those are part of extra precaution. The neutropenic precaution, what do we do for that client?
Positive pressure.
No. Neutropenic? What is neutropenic? Why is the patient on neutropenic precaution anyway? Say it louder. The white count is low. Okay, so how are we protecting this patient with a very low white count?
Only necessary contact, like
Okay, yeah, if you sick, no, we are definitely playing security guards. If you sick, don't come near my patient. Leave my patient alone. I'm securing you. I'm going to be, okay, that's one. What else?
Wear a mask.
Wear a mask. That is true. What's another thing? What education are we providing this patient who's on neutropenic precaution?
How to keep their environment clean.
Okay, cleanliness.
infection.
Trauma.
Okay, prevent trauma. Yes, okay. What else? There's something also very important. My blind self. Protect the patient from bacteria. Yes. But what? There's something else with neutropenic. Y'all gotta know this. NCLEX, if there's a chance you could get this on NCLEX. Plants, fruits. What about it? No, what about plants and fruits?
To eat them.
No, not to eat them. Not to eat them, but what? What do you know?
They have bacteria.
Okay, so no fresh fruits, no raw. Okay, for those of us who like raw egg. Okay, I do not eat raw eggs, by the way. No raw meat, no raw foods, no fresh fruits or plants.
Oh, that's why when you're in the ICU, they say don't bring real plants.
If the patient is on neutropenic precaution, yes. If their white count is low, definitely. ICU, they are very, very strict. Some will tell you they might not even let you in. Okay? Do y'all understand that? Because what did you say? Why? Because they have what? Bacteria, especially those fresh plants. There's bacteria in that soil. Okay? Boom, the patient is just going to make matters worse for that client. That's for neutropenic precaution. Okay? I don't want y'all tripping up on me and I say the patient is on contact precaution. What's the intervention that the nurse will implement? And then I put no fresh fruit and then you pick it and I'm going to look at you like, I'll just give you the look. Don't play with me.
Isn't one of them no standing water?
That's the neutropenic. Very good. Okay, people. This is where the debate begins, I think. Is it here? I don't think it's this one. Okay. Pay attention to the setting. in the scenario, the care is not always the same in every setting, When the patient is in the hospital setting, everybody is going to be on standard precaution because why? You as a healthcare provider are going from one patient to the next, to the next, to the next patient. That's in the hospital or clinic setting, right? When the patient is at home, is the care the same?
No.
Why not?
Hand hygiene most of the time.
Huh?
Hand hygiene,
What about hand hygiene?
it may not be done properly or the environment's
The
not
precautions
sterile
aren't
or
the same.
So the precautions is not the same. Okay? You still are encouraging your patient to maintain a clean environment, perform hand hygiene. However, so what you're going to do is make sure, for example, you all up in their business a different way. You want to know, hey, is your refrigerator working? Why is it my business as a home health nurse to be looking at your refrigerator? I'm just here to take care of you.
bacteria.
Emphasize, elaborate a little bit more.
It's not cold enough.
If it's not cold enough, yes. You see what I mean? Because I want y'all tripping up on me on these questions. Why would I look? Do I need to be concerned about your stove not working? Yes, why?
Because you have to cook certain foods to the proper temperature.
Thank you. Don't trip. Don't trip. Be like, oh, that's not my duty. I ain't no mechanic. It is your duty to make sure. Now, I didn't say you have to fix it. I just need you to know if it's working or not. Okay? The same thing. You're gonna make sure they're cutting boards. There's a big thing with cutting boards. Why am I concerned if they even have a cutting board and how they use their cutting boards? Huh? Say it. It's a breeding ground. So you want to make sure if they're using it, that they're cleaning it effectively, right? So wash raw fruits and vegetables if they're using it. Use pasteurized milks and fruit juices. Of course, you're going to teach your patient to wash their hands after they use the bathroom. If they go home with a PICC line, for example, you're telling them what to look out for, the signs and symptoms of an infection, okay? If they were in a hospital setting, if we had to change it, we would be wearing a mask. But since they're at home, they don't have to wear a mask. Okay, those kind of things. But they do need to know the signs and symptoms that line is infected. They need to tell people, guests, they need to be cognizant of the fact that if other people are sick, other sick people can't be around them. They just gonna have to know that, all right? And don't try to say, oh, it sounds rude. Okay? Don't play with me, all right? And of course, use individualized care items rather than sharing. So in other words, each equipment that they use, need to use maybe a spoon, eating utensil, or whatever. If they can be isolated specifically for themselves only, the better. Okay. All right. Boom, boom, boom. Our goal, of course, is to maintain free of infection, symptom free, and you can identify unsafe environments. Okay.